So we'll kick off session 1 here. I'd like to introduce the moderators for this session. The topic is Global Challenges, Global Solutions. Dr. Jill Koshiol is one of our moderators. She received her PhD in epidemiology from the University of North Carolina at Chapel Hill. She thereafter joined the National Cancer Institute, where she is a senior investigator in the Infections and Immunoepidemiology branch of the Division of Cancer Epidemiology and Prevention. She has focused her research on biliary tract cancers, which include gallbladder cancers and, of course, cholangiocarcinoma. She is one of the world's leading authorities in the epidemiology of these diseases. Accompanying her to moderate is Dr. Heinz-Josef Klumpen. He's a medical oncologist specializing in gastrointestinal cancers, which include cholangiocarcinoma, at the Amsterdam University Medical Center. He earned his medical degree from H. Hein University of Düsseldorf in Germany. He has mainly practiced in the Netherlands thereafter. Of interest, he has a PhD in pharmacy to accompany his medical training. I will turn over the stage to Drs. Koshiol and Klumpen to take over the session.
Well, as others have said, it is an honor to be here. It's always a joy. This is such really a special conference that gives us the opportunity to really bring the entire community together. And it is a particular privilege to moderate this session to really discuss global challenges and opportunities. So I am especially honored to have the privilege to introduce our first speaker, who is Dr. Bruno Nervi. He is a medical oncologist, and he's also my personal friend and colleague. We've had many opportunities to talk together about the challenges and opportunities in Chile, which he will be discussing today. He is an associate professor at Pontificia Universidad Católica de Chile in Santiago. Bruno, I'm going to keep it short because I know there's very little time, so please come and tell us about the challenges in Chile today.
Thank you for the introduction. It's a pleasure to be here, and I really thank you for the opportunity to remind me that we are working and giving our life as researchers for our patients. So I hope to bring all this passion to my country. So I work in the university, but I work very close with patients and advocacy groups because I'm the president of a foundation. And now I have been involved in the last few years in the government to try to make stable changes in the country. So I'm the director of a Center for Cancer Research to impact public policies. And I have permission to talk about the orphan biliary tract cancer, that is gallbladder cancer. So I'm sorry, I'm going to focus a little bit the problem in gallbladder cancer because this is the major issue in biliary tract cancer in my country. So the global challenges that I face for my country are, first, we have a great inequity. We have different opportunities for people in my country. 20% have private insurance, and we have the best opportunity as you can have here in the States, but 80% not. And they could be waiting 6 months before to have the diagnosis done. We have poor research, poor investment in health, and we have a lack of specialists. So the global solutions we are facing in my country is to show that cancer is a problem of everybody, not just for the Ministry of Health, to recognize the gap. We have 17 radiation machines in the country, and we need 45, and this is written in our cancer law. We have to empower civil society, and we have to do research for people to impact public policies and inform decision makers. So from the perspective of gallbladder cancer, we have a kind of nature experiment in my country. Salmonella typhi seems to be involved, and we had a pandemic that I'm going to show you in a couple of minutes. We have a Mapuche ancestry, so the Indian background of my country is very relevant because women, especially if they have obesity, they have gallstones and gallbladder cancer. And we faced, from the 70s till now, duplication or triplication in the incidence and mortality, and now we're facing a reduction. So gallbladder cancer was the first cause of death in women in my country 15 years ago, and now it's the 5th. And probably it's going back and it's going to disappear as a major problem, so we have a window of opportunity to do research and to learn. So we implemented 20 years ago a national cholecystectomy program, and we have done 30,000 cholecystectomies a year, so 300,000, to try to prevent gallbladder cancer. We don't have an evaluation of this program, so we really don't know if this was a good idea. We have 3 deaths because of cancer in my country every hour, one where the person had no opportunity to be treated. So this is colorectal cancer, and in blue you have the overall survival for a patient with colorectal cancer and private insurance, so 65%. And if you have FONASA, it means the public system, healthcare, you have an overall survival of 30%. And this is just to show you we are trying to map with our research cancer center the opportunity. We're trying to do that in cholangiocarcinoma. So this is the investment that we have in the country in research. You can see in the top with different colors what the government or what we invest in research in the universities for cancer. And in blue, you have the private international funds financed by the industry for clinical research for the industry. This is coming up. In fact, we run clinical trials the same as you, but the research to solve our problems is really small, so we have to improve that. This is my country, and the stars are the medical oncologists. We are just 180 for 20 million people, and we should be 400 at least. And the majority is concentrated in the capital city, in Santiago. So the training of people is one of the major problems that we face. And we have a poor health spending, so these are the US dollars per capita, and you can see how we have 2,700, and here you have 12,000. The ancestry of our population is very important in the risk to have gallbladder cancer. You can see in the dark color in the left, the Mapuche ancestry that is concentrated in the southern part of my country, and in the right side, you have the incidence of gallbladder cancer that it matches with the Mapuche ancestry. So the Salmonella typhi has the reservoir in the gallbladder. And both gallbladder and salmonella occur in poor areas in my country, in India, and in Korea. So 3% of infected become chronic carriers in the biliary tract, and it could arrive up to 40 if you have gallstones. And chronic carriers have 3 to 200 times higher risk for gallbladder cancer. And it means near 6% lifetime. And gallstone carriers have an OR up to 6 times to have cancer, but less than 1% lifetime risk to have cancer. So here you can see in the left the incidence of typhoid fever in between the 50s and 2006. And we had a peak from the 70s to the 90s. And you can see in the right side how we had an increase in the incidence of gallbladder cancer starting near the 80s. And what we're facing now, there you have from the 70s up to 2020, the incidence is coming down. And this is because of the Salmonella typhi is not just a problem in the country, but we implemented in 2006 a program to remove gallbladder if between 35 and 49 years old if people have gallstones. And we really don't know if this is going to be a good idea because the percentage of people developing fat liver or diabetes after the cholecystectomy, apparently it's a major problem. but we have a faster reduction in the incidence associated probably with this program, because people who had 35, 20 years ago, it's arriving to the time when they could have developed gallbladder cancer. So this is the cholecystectomy numbers that we do every year, 30,000. And we have different research groups. Jill liderates one of the largest programs in the country to try to recognize serological markers or genetical markers to try to stratify the waiting list for cholecystectomy, because one of the major challenges is to choose what person must have removed the gallbladder. So just to finish now, what are we doing to face cancer problem in the country? So in 2018, our Ministry of Health decided to say that cancer was one of the major problems in the country. He looked what we were doing from the civil society to try to improve the opportunities in the country. 10 years ago, we had troubles to give chemotherapy in the country, and now we can give some biologics. So we designed the first national cancer plan that we gave to the president, who is in the left, and the plan marked the gaps that we have in the country. And the objective of the country was to reduce these gaps in 10 years. In the middle, you can see in 2020, with people in the streets, we request the necessity to have a national cancer law. And we obtained that in 2020. That means that we can have a special amount of money every year, that we must have an obligatory cancer registry, and we implemented a tax benefit in our laws. And in the right, we had the National Cancer Plan, we had the cancer law, but we don't have data for policymakers. So we implemented the largest, as kind of R01 in the country, is the largest research program. These are $6 million to develop a research cancer with 90 researchers, 10 centers in the country, to do research in cancer just to impact public policies. So we want to understand the gaps we have in the country and how to reduce the waiting list and the time between diagnosis and treatment. And this is the Center for Cancer Prevention and Control. So the global solutions empower the civil society. This has been the most important thing in my country in the last 10 years, because we are requesting with patients what it's fair in terms of opportunity. Thank you.
Thank you so much, Bruno. Very interesting to see how it's going on in Chile. We are looking forward to the next presenter. It's Teresa Macarulla. She's a medical oncologist at the Vall d'Hebron in University Hospital of Barcelona. She's the head of the GI tumor group. She will give us an overview of the situation of biliary tract cancer in Spain. Please, the floor is yours, Teresa. Thank you.
So thank you very much for the introduction. First of all, of course, I want to thank for the opportunity to be here today in this new edition of Cholangiocarcinoma Foundation Congress. And also I want to congratulate the chairs, but also all the team that organized this meeting. So I will talk about the global challenge and global solutions from a Spanish, but also European perspective. So first of all, in this slide, as you can see, I highlight three of the main, for me, challenges in biliary tract cancer in Europe. First of all, the cholangiocarcinoma registries, also the design of clinical trials and how we have a small number of patients in each subgroup of targetable alterations, and the process of drug approval in Spain and in Europe in general. So first of all, regarding the cholangiocarcinoma registries, so I want to start with this slide, in which you can see the number of new cases that it was expected in Spain in 2023, and this was published in 2022. And as you can see, we have the number of liver cancers, you have the number of gallbladder cancers, but we do not have the specific numbers of intrahepatic cholangiocarcinoma, perihelial or distal cholangiocarcinoma, or we do not have the numbers of ampullary cancers, for example. So here we have a lot of work to do. So I hope with the new classification, international classification of cholangiocarcinoma, this anatomical classification with the intrahepatic, clearly differentiate the intrahepatic, perihelial and extrahepatic, we can improve the codification of the patients with cholangiocarcinoma and will help us to know how many patients we have in our country. In these regards, in order to have better epidemiological data of cholangiocarcinoma, the European Cholangiocarcinoma Network, and thanks to this cross-grant action grant, they can establish this European Cholangiocarcinoma Registry, and specifically also a specific histological registry and radiological registry, and the different countries in Europe, we can collaborate with our patients to this registry. This, fortunately, will help us to have a better data. And what about in Spain? So once we see these numbers, and we didn't have a really picture of the situation in our country, and we don't know how many patients are diagnosed in each subtype of biliary tract cancer. So for this, we create this database that is in the context of the GI cooperative group in Spain, the TTD group. We create this database for the biliary tract cancer patients, and the intention is that each newly diagnosed patients with biliary tract cancer has to be introduced in this database, and this can give us a better picture of what is happening in our country, how the patients are treated, which are our overall survival or whatever. Also, this helps us to create a network of oncologists who are dedicated to biliary tract, to cholangiocarcinoma in our country, and also it allows us to have international collaborations, for example, with a small group of patients in our database, and we can share with other databases in order to have better information. Regarding the clinical trials and the design of clinical trials in general in cholangiocarcinoma, and there we will talk about the specific solution that have in our country. So first of all, we know that intrahepatic cholangiocarcinoma presented a higher incidence of targetable alterations, but also it's true that there's a small percentage of patients in each of these targetable alterations. So how we can design clinical trials and then allow us to have approvals of the drugs in our countries. So we have only this phase 3 clinical trial randomized with a control arm that is the Clarity trial. As you well know, patients with IDH1 mutations can be treated with ivosidenib, IDH1 inhibitor, or observation. But of course, the crossover was allowed in order to give to all the patients the opportunity to be treated with the experimental treatment, ivosidenib. But for this, of course, it was not possible to have the primary endpoint of overall survival, and our primary endpoint was progression-free survival. Still today, the regulatory agencies or some of our countries, the Ministry of Health of our countries, ask us for overall survival, and that's a problem in this kind of trials. Of course, the trial was positive in its primary endpoint, progression-free survival, but because 70% of the patients treated in the control arm can be or did the crossover to ivosidenib, we did not have impact, statistically significant impact in overall survival. That's something that we can expect it if 70% of the patients from the control arm are treated with the experimental arm. So that's something that we have to improve in order to have easier access or approval of this kind of drugs. In our group, our team from my hospital in Vallebron, we tried to do this, or we presented this data in the last ASCO meeting. This is a meta-analysis of randomized trial, but also individual patient to try to correlate the progression-free survival that we have in these trials with the overall survival in order to convince the regulatory agency or also our Minister of Health that sometimes in some trials in which we have crossover, it's very difficult to have impact in overall survival. Regarding the trial level, that we include 32 clinical trials, randomized clinical trials, we have a PFS of hazard ratio of 0.69 as likely results in the impact in PFS with overall survival. And then also we have the individual level of the patients, and also we have a strong correlation between PFS and overall survival. What it is interesting is that now we we are putting more patients in this analysis. We include patients from randomized trial, individual data of these patients from randomized trial in first line, in second line, and also we include real-world data from other groups apart from our group in Spain. So we hope with this we can convince the authorities that they can approve drugs only with impact in PFS if there's crossover. And of course, we have some small number of patients, or percentage of patients, that the activity of the drug is demonstrated in single-arm phase 2 trials with no control arms. And again, this is a problem in our country to have the approval. This is another example, the pan-tumor trials, because a small percentage of patients presented some alterations. Some clinical trials include different tumor types with one alteration. For example, the Destiny pan-tumor trial, in which patients with HER2 overexpressions are treated with trastuzumab deruxtecan, and we include some patients with biliary tract cancer. So this, again, how we can have the approvals of this kind of trials in Europe, and specifically in our country, so it's difficult. So we propose not to have randomized data. Some of these trials have an approval for FDA, but conditioned to randomized data. So what we would like to have is not to need randomized data, for example, to use historical real-world data, historical controls. So to use same population, for example, with HER2 overexpression, what we treated with other treatments. And with this, we will have this data as a control arm that the Ministry of Health, for example, in our country, ask to us in order to approve this kind of drugs. And what we want to avoid is to have situations like this. No, this is a clinical trial with really problems, huge problems to recruit the patients. This trial is trying to recruit patients with FGFR2 fusions in first line, and treat the patients with pemigatinib or standard of care. But the problem is, first of all, that it is very difficult to find this population. It's very difficult to wait the time that we have the results of the NGS analysis. It's a majority of patients, of course, will do the crossover because patients treated with chemotherapy will have the opportunity at progression to be treated with the FGFR inhibitor, and with this, of course, we will not have impact in overall survival. We will have impact only in progression-free survival. So really, and again, also during all this period of time in which the trial it was open, the standard of care changed. So now we cannot include patients in this trial because the standard of care is cisplatin, gemcitabine, and immunotherapy. And here it's not included in the trial. So very difficult situation. And then so we have to try to avoid these situations. And what about the drug approvals in Europe, and specifically in our country, in Spain? So here is this article published by Angela Lamarca and Arnold Boger in which they bring to us the situation of FGFR approvals, inhibitors approvals in Europe. And as you can see here, the situation is really different in different countries. So once you have the approval by the European agencies, then to have the reimbursement decision in the different countries, it takes a lot of time in some of them. And this, of course, during this period of time in which we do not have the reimbursement decision, it's very difficult to treat our patients with that drug, so the patients cannot be treated. So approvals by the regulatory agencies in Europe does not always mean reimbursement being in each of the countries. So we have different situations. In general, countries in the north of Europe or southern Europe can have access to the new drugs after the EMA approval between 100 and 200 days. But then we have countries in the north, in the south or eastern Europe that can have to wait maybe 600 or 1,000 days to have the approval. So that means that there's a huge inequity in the different countries in Spain, in Europe. If we go in detail in our situation in Spain, you can see here the drugs. Maybe you can see it's a little bit small, but you can see the situation in Spain. Here we have the drugs that are approved for biliary tract cancer in Spain. Pemigatinib, it took more than 1,000 days to have the reimbursement in our country after the EMA approval, and that's more than 2 years. Futibatinib was luckier, and it was a shorter period of time, 9 months, to have the approval. And ivosidenib is not approved yet, but we have the approval of EMA, but it's not approved yet in Spain. Then we have the situation of durvalumab. It takes 18 months to have the approval or reimbursement decision in our country after the EMA approval, and we do not have today the approval of pembrolizumab in our country. So to sum up, regarding the cholangiocarcinoma registries, it is important in order to have the correct codification of the cholangiocarcinoma in order to know the number of patients that are diagnosed in our country and in Europe, and also the importance of the local and international registries and the collaboration between them. Clinical trials design very complicated in this disease, a small percentage of patients with specific alterations, so some of those trials has no randomized data, of course no impact in overall survival sometimes. The crossover has to be allowed because patients have to have the opportunity to be treated with experimental arm, but with this there's no impact in overall survival. I think the real world data, we can use this as a control arm, and we don't need to use randomization in this specific group of patients in which it's so difficult to have an impact. It's so difficult to run this kind of trials. And finally, the drug approval in Europe, it's very complicated, variability in access of the drugs in the different countries, and a huge inequity in the different countries in Europe. And thank you for your attention.
Thank you so much, Dr. Macarulla. Next, I'd like to introduce Li-Tzong Chen, who is a professor of biopharmaceutical science and the deputy director of the National Institute of Cancer Research in Taiwan. He specializes in hepatopancreatobiliary tumors. Professor Chen.
Thank you, Mr. Chairman, for your kind introduction. And first of all, I'd like to thank the organizing committee to give me the opportunity to come to this beautiful city and also have an opportunity to share in our thoughts about pediatric cancer in Taiwan. I think from the epidemiology, because Taiwan is not a member of the WHO, so actually you are very difficult to find the cancer data from the WHO publications. So here I show you that pediatric cancer has been, especially intrahepatic cholangiocarcinoma. The major risk factor was HPV infection, HCV infection, intrahepatic stone, and also liver fluke infection previously. But in Taiwan, we have a very successful HPV vaccination program and also have a HPV-HCV interventional project. So that you can see from the left side panel that the hepatocellular carcinoma incidence have dropped dramatically, especially for the age-adjusted incidence rate. That decreased from nearly 40% to 21% in the past 20 years. But actually for the pediatric cancer, you can see overall the incidence, age-adjusted incidence will remain consistent, about 5%. From the right side low panel, you can see for the intrahepatic cholangiocarcinoma, the incidence still is rising as compared to the hepatocellular carcinoma, the decrease of the incidence. While the gallbladder and the extrahepatic cholangiocarcinoma, the incidence appear to be quite consistent. And overall, the incidence of cholangiocarcinoma in Taiwan is about 5 per 100,000 populations. And when we look at the age-adjusted incidence curve, that is by the period analysis. From the left side, you can see for the intrahepatic cholangiocarcinoma, the age-adjusted incidence was increasing for the aged people, continue rising in the maybe past 15 to 20 years. But when you look at the right side panel for the hepatocellular carcinoma, mainly in male patients, now we can see for the hepatocellular carcinoma, the incidence is decreasing, and also even in the aged population, also in the past 15 to 20 years. We don't know the exact reason, but one of the possibility causes is the cholangiocarcinoma etiology may be more complicated as compared to the hepatocellular carcinoma. But I think this is a very interesting topic that may deserve further investigation. And from this figure, you can see in the low panel that is the first-line and second-line drug that have been approved for the cholangiocarcinoma by the FDA. But from the upper panel in the middle, you can see there is a reimbursement in Taiwan. Before year 2023, Taiwan only have a gemcitabine has been approved by our government for the treatment of the cholangiocarcinoma or the biliary tract cancer. Only in year 2023, we have a pemigatinib, and we also have a larotrectinib for the treatment of the FGR fusion, FGR2 fusion, or the NTRK fusion patient. And in this year, we have a S1 also have been approved. So this is a drug approval currently in Taiwan. So even Taiwan national insurance, health insurance has been considered one of the best in the world. But because the budget is limited, so there is a budget competition. And cholangiocarcinoma is a small cancer type, so the budget actually also relatively small as compared to the large cancer type. For example, breast cancer, colorectal cancer, and especially for the lung cancer. So for the cholangiocarcinoma, as you know, we have a good screening test. So most of the patient was diagnosed at this stage. And the other is a lack of access for the advanced technology. For the diagnostic technology, I think our national insurance cover is very good. So what we take is actually is a genetic testing, that is a cancer panel, NGS testing. Currently, until now, our national health still not covers such kind of genetic testing. And so we are also less likely to receive the guideline concurrent treatment, as you can see, because of drug approval. Consider the budget is big for the precision medicine medication, so most of the medication were not approved. So in such case, I think one of the ways that maybe we can consider to reduce the cost for the precision medicine is maybe we can try to use the optimal dose rather than the maximal dose verified by the pivotal clinical study. And because of the lack of NGS testing, as you know, in current study, a lot of the study require the NGS testing, so that they also impair our patient to participate in the clinical study. And the other concerning is that a lot of the clinical pivotal study using a so-called flat dose design. As you know, some of the people's the body weight and also the body surface is relatively small as compared to the Western population. So our patient may expose to more drug and have a higher toxicity, and that's also one of the advantage for the clinical trial participation. And so how we do dealing with this? So now you can see that the drug reimbursement in the middle and in the upper panel. Actually, in the past 20 years, we try to use some of the investigator-initiated clinical trial, try to cover this kind of the drug deficiency. So initially, we have a JMOX we saw without cetuximab, and then we have tried to have a phase 2 study to combine gemcitabine S1. And then we have a phase 3 trial, actually try to compare gemcitabine cisplatin with a drug regimen we developed called the SLAG, that is gemcitabine, oxaliplatin, and the S1 leucovorin. And then we have a nivo plus gemcitabine S1 treatment regimen. And finally, we have a second line, lenvatinib plus paclitaxel. And from year 2021, we have a national research program try to provide NGS for the patient with a cholangiocarcinoma. And that really helped a lot. So this is NGS data from our study NGS program. You can see most of the patients, actually, we can identify a lot of the patients that have a actionable genetic alteration and enable we to include the patient into the clinical study. And we also can try to explore our clinical study to associate with genetic alteration, try to improve their treatment outcome. For example, this is a TCAR 1219 study that we use nivolumab in combination with gemcitabine and S1. And in this study, you can see the grade 3, grade 4 neutropenia only less than 10%, but we can achieve a nearly 50% of tumor response. I know the response is relatively high because it's a phase 2 study. Maybe it has some kind of the patient selection. In this study, we use Nivo, is a 240 milligram per square meter every 2 weeks. And actually, in our translational research, we found a patient with tumor mutation high have a very good tumor response. As one of my patients that include into the study, the patient have a liver disease and also very extensive para-aortic lymph node metastasis. But after the treatment, the patient have a very nice response. And so after 12 months of treatment, the patient receives a conversion surgery. Because he's a professor of the art, so he declined all the adjuvant treatment after that. And then the tumor recurrence only 9 months later. And the patient have a TMB high, that is 10.6 mutation per megabase. Based on this finding, actually in the clinical practice, patients have to pay their immunotherapy from their pocket. So based on the phase 1 study and also some of the study from the India suggests low dose immunotherapy actually can be active. So in this patient, when the patient presented with a massive pleural effusion and a retrocardial lymph node metastasis and also retroperitoneal lymph node metastasis, and the patient have also very severe liver cirrhosis and hyperspllenism. So we treat the patient with a Nivo 100 milligram every 2 weeks in combination with gemcitabine at 600 milligram per square meter. You can see the patient initially have a very nice tumor response, but because of toxicity, he have a decreased treatment usage and the tumor progression, and we start the treatment again. The patient currently still receives the same treatment every 3 to 4 weeks. Currently still in our clinical practice. And the other is as we know, the liver cancer, some have presented with a hypervascular tumor. So this patient have failed to gemcitabine cisplatin, presented very extensive liver metastasis hypervascular. So we give the patient lenvatinib treated as a hepatocellular carcinoma. The patient have been under control for nearly 12 months with a single agent of lenvatinib, 10 milligram per day, and then reduced to 5 milligram per day. In our translational research, we found tumor cholangiocarcinoma in the starvation situation, their major VEGF-C will be increased. That also increase phosphate VEGFR3 of the cholangiocarcinoma. Based on the study, actually, we are currently now running a clinical study with a second-line treatment with lenvatinib plus paclitaxel. That study is currently ongoing. So I think this is my conclusion that in the era of the precision medicine, I think financial barrier and also disparity in cancer patient care treatment can become more and more critical. So I think to provide affordable, accurate diagnostic method and also effective safety regimen should be our mission as well. Thank you.
Thank you so much, Professor Chen. Very interesting, another country, another problems. I have the pleasure to introduce the next speaker. That is Vikas Ostwal. He's a medical oncologist at the Tata Memorial Center in Mumbai, India, specialized in GI cancers. I hope Vikas is there. Yes, he is there. Fantastic. Please come to the stage. We are looking forward to your presentation on the situation in India. Very easy, I suppose, with such a small population.
I thank the organizing committee and Cholangiocarcinoma Foundation for inviting me to this wonderful meeting. I'm humbled and honored. Gallbladder cancer is our problem, and I'll be talking about gallbladder cancer especially. And I'll run through epidemiology, advanced disease, and resectable gallbladder cancer treatment, and what are the challenges overall we see. If you look at this epidemiology chart. I'm not sure it's clearly visible. Yeah. So India, we have a northern part of country and eastern part of our country, especially present with gallbladder cancer. This is along the Ganges belt, the Ganges River, and the incidence can be as high up to 22 per 100,000 gallbladder cancers. Now, essentially, we were part of the research group, and there was a finding where the cooking oil, mustard oil, was one of the contributing factor for presence of gallbladder cancer. Gallstones contributed only 10%. There was data from our colleague in this area. We're talking about arsenic in the water of Ganges River. There are multiple factors involved in possible pathogenesis and causation of gallbladder cancer. Going ahead, I work at the Tertiary Cancer Center, and we see about 400 advanced gallbladder cancers per year. Now, this is a heavy workload, and we do see most of them coming from the northern and eastern part of our country. As I mentioned, they are 70 to 90% patients present with the advanced disease, and usually they are classified into under the umbrella of biliary tract cancers, and the data cannot be extrapolated because it's just the 20% of gallbladder cancer in most of the trials. When we see 5 gallbladder cancers, 1 cholangio, that's the proportion what we see in the clinics. And we need to have multi-centric, multinational collaborative trial, especially as we heard Chile data by Dr. Bruno. So we usually, when we have patients presenting with simple cholecystectomies done for gallstones, these are the laparoscopic surgeries, so there's always an inadequate evaluation. We definitely miss the malignancy, or even if it is diagnosed or removed properly, about 60% of time the pathology colleagues at the local place might miss the presence of cancer, and the patient is given false hope that everything is fine, it's just a stone, and go home, and then they're lost to follow-up, and then they come back with advanced disease. Not to forget a port site metastasis and seedlings. And when they present with the advanced disease, there's delay in reaching the tertiary cancer center and arranging funds for logistics, initial assessments, stenting. And gallbladder is a different disease than cholangio. I mean, I heard the story and James' story and many. We can still wait for 4 weeks, but in gallbladder, you wait for 3 to 4 weeks, the patient is deteriorating. And that's my next point. When there is a delay in the treatment by 3-4 weeks, the performance status and overall general condition will deteriorate. That's the greatest challenge what we face. So we have to be on toes for these patients. And draining the obstructive jaundice, most of the time the battle is often lost because of the drainage, the recovery from that. And immune checkpoint inhibitors and most of the targeted therapies are available and possible for only 1 to 5% of the patients. These are all out-of-pocket expenses, and most of the government schemes or government reimbursement will not cover these high-cost drugs. Just to make a mention that we have immune checkpoint inhibitors, but we do not have any targeted agent, saying FGFR inhibitor or IDH1 inhibitor. Now, looking at this, these challenges, what can we do for this patient? So probably these are the fragile patients, and can we give them a good quality of life with the lesser toxic treatment and prolong their life? And we did this study in second-line gallbladder cancers and looking at 2 drug versus 1 drug therapy. I'm sure FOLFOX is difficult for our patients after GEMSIS, but we concluded that 1 drug therapy is sufficient for our patients to give equivalent survival. This was the audit what we did, and we decided whom to treat and whom not to treat, because we had to triage these patients. There's so many patients coming across, and we found that those have multiple sites of disease at the presentation, or they're not able to continue their first-line therapy without toxicity, and they're not fit for second-line therapy. These are the module what we decided, and probably the median survival was 4 months in spite of the therapy. So we thought this patient probably should go home early. On the contrary, if we had good performance status patient, we gave this triplet based on the SWOG data, and overall response rate was almost 68%, and about 35% patient got operated. So these were the locally advanced gallbladder cancer with a heavy burden of disease, liver infiltration, but they got downstage, and they got operated in 35% of the times, and median survival crossed 14 months. What are the opportunities? What we see in treating these patients is what we do is we go aggressive. We are aggressive on providing the supportive care, taking help of government bodies, NGOs, and that is a lot in India now. So we arrange funds for their initial assessment, stenting, and also there are trials which are ongoing with the help of our Indian Council of Medical Research and the local organization funding the low-dose immunotherapy, low-dose immune checkpoint inhibitors trials, and looking at certain targets. So now, as we all know, gallbladder has about HER2 in about 10 to 15%, and our patients, we saw about 13% patient had HER2 positivity, and so we looked at these targets so that we can improve the survival. We also looked at whether in place of immune checkpoint inhibitor maintenance therapy, can we give something different, which is low cost and feasible in our country. So these are the two trials which we looked at, and addition of trastuzumab in first line, gemcitabine cisplatin trastuzumab, help our patients to improve their progression-free survival. This was another study which we my colleague presented last year, ASCO, where we used bevacizumab erlotinib maintenance therapy after 6 months of chemo, and versus observation, and there was doubling of progression-free survival. So we could benefit, and we could arrange an alternative option when we cannot give immune checkpoint inhibitors. Now, we are running this phase 3 trial with triplet versus doublet to find where we can give best possible survival benefit to our advanced gallbladder cancer patients. Now, this is something which I wanted to highlight, where what are the collaborative work we are doing. So we have this center, Tata Memorial Center here in Mumbai. And under the umbrella of Tata Memorial Center, we have centers in the northern part of country, 2 centers. One is in Uttar Pradesh, one is in Chandigarh. The other centers in the eastern part of our country, and there are some private players who are willing to collaborate, and there are multiple collaborative trials we are doing. Some are published, some are ongoing. And the advantage is that if there is a straightforward research question, our governmental body and our local body are willing to provide funding. And that's something changing that's a big solution for our patients. Just to touch upon the resectable gallbladder cancer, we don't find our patient comfortable taking capecitabine by BILCAP or S1 by ASCOT because of the tolerance issue, and we do give them Gemcis. And this was started way before BILCAP came, and this was the study looking at Gemcis versus capecitabine and chemoradiation. And just to summarize, there were very few collaborative trials earlier. Now the scenario is changing, and we try to ask a core scientific question, appropriate resource allocation, and in an Indian scenario, and that is a very important thing in our country. Involvement of the patient, and which I learned a lot here today, that would improve the participation in the clinical trial, which is most of the time patients refuse to participate in the clinical trial, and improved funding would help our patients a lot. Thank you. Thank you for your attention. If you have any questions, let me know.
Thank you so much. I love hearing about gallbladder cancer, and I can't wait till we get to have more discussions about it. In the meantime, I am super excited to introduce our next speaker, who will be joining us online. This is Dr. Watcharin Loilome, an associate professor at Kon University in Thailand. Her focus is on liver fluke-related cholangiocarcinoma. And hopefully, she'll be coming up soon. Okay, here we go.
Okay, good morning. Thank you so much for your kind introduction, and also thank you, the Cholangiocarcinoma Foundation, and also the organizing committee for letting me to join this meeting, and also sharing you guys what we are doing in terms of combating cholangiocarcinoma in Thailand. Okay, I would like to say that what I'm going to talk of the credit would go to, this great man, Professor Narong Khantikeo, the one who dedicated all entire of his life on combating cholangiocarcinoma in Thailand. So my talk today would start with the background of disease in our area, and also I would like to share with you guys what the work that we are doing here in Thailand, and then also what would be the next challenge for us. I think you are familiar with this map, and also I would say that I'm now sitting in the place where the highest incidence of cholangiocarcinoma in the world has been reported, especially in the northeastern part of Thailand. And then if you look at the new cases in number in Thailand, I would say that we have approximately 20,000 new cases a year here in Thailand, especially in Northeast and also in the northern part of Thailand. Unlike in Western country or other places in the world, our cholangiocarcinoma is quite unique because we have the major risk factor, which is the liver flukes Opisthochis viverrini infections. And then you can see this is the live worm that we got from the operation theater. And then you can see, so this is the specimen that we got from the operation theater. And then you can see the presence of flukes, habits in the bile ducts of the patients. And also the people in our area, they do have, raw fish eating habits. So this is the kind of fish that, can be the host for the OV infections. And then you can see this is the infective state of the flukes in fish. And then this is the very complicated life cycle of the fluke, which is involved like humans at the host, cat and dog, and also several intermediate hosts, for example, the snail and also the fish. So this is why, actually we found that we can discover this fluke over 100 years ago, but it's still our problem until now because the life cycle is very correlated to the eating habit. And then if we look at the number of fluke infections in our populations, I would say that if you bet on the fecal examinations, so the Ministry of Public Health is quite proud with the number because they said that, okay, we have about 10% of people getting infections. But if you base on the new technology that the cholangiocarcinoma is still, we just invent the urine detections, the antigen detection in the urine. So then we show that the incidence of infection is about 40% in our population, which means nowadays in Thailand, it is about 10 to 12 millions of the people getting infection with the liver fluke. And as I mentioned, 20,000 of cholangiocarcinoma new cases a year that we have. And then actually we have quite long history of combating this disease. So we started over 40 years ago at the research center, with mainly doing research to find out the knowledge and also the try to develop the innovation to combat this kind of disease. And then about 10 years ago, leading by our ex-leader, Professor Narong, we took the knowledge and also the innovation, the tool that we have to be working in the community in terms of, problem solving. And also at the same time, Professor Narong established also the Cholangiocarcinoma Foundation of Thailand to help in this work. And then this is our goal. We would like to make the solutions using the research as a tool and bring all solutions to solve the problem for the people. And then this is, I would say that we have a big team, basically comprised with, the researcher, the clinicians, also the people in many aspects, because the problem is not that just the health problem, but it also involves the other dimension as well. And then as the Institute, we working together. We have the Cholangiocarcinoma Research Institute that, playing mainly role in research. And also we have the Cholangiocarcinoma Excellence Center with playing mainly on the treatment and also the trainings for the people who get involved in cancer treatment. And also we play role as a hub of knowledge to transfer the knowledge or technology that we have to the other sector that involved in the problem solving. And also we have both, the national and also international level collaboration to work together. Actually, I would say that one problem, but anyway, as I mentioned, is involved in many dimensions. So we have many things that need to be done, starting from for example, how to do preventions, especially for the fluke infections, and also how to do the screening for the one who get infection with the fluke, and also the one who are, being cholangiocarcinoma, and after that, how can we do for the treatment, thing like that. So it's one problem, but many solutions need to be concerned. And also, I would say that we work starting from the primary, secondary, tertiary, and also the end of life care. So many things need to be done in holistic approach. And then nowadays we have tools to work with it, starting from the big data called ISAN cohort that we use to register the risk people and also the patient. And also we have the screening system, the ultrasound system, which is now the AI diagnosis for the screening for the cancer people. And also we have the OV kit, the urine detection kit. And also we do, the school-based curriculum in terms of fluke and cancer preventions. And also we have, many kind of media that we need to communicate with the people in all levels. And then this is the picture of our activity, as I mentioned, ranking from the prevention in school. We do the mass screenings, both liver fluke infection and cancer, and also we do treatment for the people. And then nowadays, as we have the same problem in this region, the sub-region, so we are now running also the projects in Lao PDR. And as a result, we successfully developed the national programs on, eliminating liver fluke and reduce cholangiocarcinoma. It's a 10-year program, but actually, I think they might need to extend the program because I think we're still far away from the successful in terms of, decreasing the number of the patients. And also we can do nowadays, like more than millions of people have been screening both for liver fluke and also the cancer. And then it's about 35,000 is now, join the program at the treatment. So this is what we are doing so far in the number. And then I think we quite successful in terms of decreasing the levels of the fluke infections. Until now, it's about 10% something, but I would say that in very specific area, in the research area, and then we can change the ratio of the cancer by using the ultrasound screenings to be more early, and then we can bring up the 5-year survival of the patients. So this is a good thing, but as I mentioned, it's a research base for now. So in this case, still a lot of challenge that we need to make it possible. First of all is how to expand the good results from our research to be routine implementations in case that we can do the problem solving and expansion to be as the nationwide program. And how can we get 10, 12 million people, risk people to be screened, both for the liver fluke and also the cancer? And then how can we deal with 20,000 new cases a year in terms of treatment? I would say that we're still far away from the word precision medicine, as you guys mentioned. And the hard thing is the genetic background of our patients quite different from the Western country because we have fluke related. So in this case, the drug that's available in the market now is not, possible from our patients. And because this problem is related to the behavior, so we still facing some of the problem of the fluke infections, especially for the new cases and also the reinfection cases. So we have to find a way to prevent these events. And also, I would say that many components need to be done, especially how to change people behavior. This is very, very difficult. And also, how can we expand the program to the Great Mekong sub-region country who, face the same problem? Because if we can do things good in Thailand, but our neighbors still have, flukes, and then the fluke don't need visa to enter Thailand. So in this case, we need to solve the problem in this neighboring country as well. And okay, everything we do, we just need to help these people. Thank you so much.
Thank you, Professor Loilome. Impressive data, I would think, to have a good structure to improve the outcome for people, and big challenges. It's my pleasure to introduce the last speaker for today before we go to the discussion. It's Professor Michael Okello. He's a hepatobiliary surgeon at Makerere University in Uganda, and he's giving us a presentation on the situation. Well, the challenge was for him for all Africa, but I'm curious how he takes that challenge. Thank you, Professor.
Thank you very much, Cholangiocarcinoma Foundation, for having me here all the way from East Africa. As a surgeon, I'll be mostly sharing the data from the hospital where I work from. I also happen to be the president for the society, so sitting from yesterday, so I'm going to skip most of my slides because some of the things have been repeated. I will not go through the introduction. I'll mostly discuss the data that we have. So this has been shared from the previous sessions. And where I come from, we have challenges starting from the diagnostics. You can do the basic blood workup, but when you come to imaging, ERCP, we have challenges. We don't have as advanced ERCP. We have 1 or 2 people able to do basic ERCP, and we don't have cholangioscopy. We don't have EUS in the whole country. And the patients, surprisingly, the patients we get are advanced. You find someone comes because of obstructive jaundice, they have cholestatic pruritus, they're scratching themselves, and that's why they've come to you to sort that out. And that is their interest. And when you do basic evaluation, at least we have a CT scan and MRI and MRCP. But like in my hospital, the CT scan we have is a 6 slice, which you can't do much with it. But at least sometimes we utilize the ones from the neighboring institutions where you can evaluate a little more. PET CT scan, we don't have a PET scan in the whole country of about 45 million people. So when I travel, I see each hospital has a PET scan. I was like, there's a big difference. So we have challenges as a surgeon, starting from the diagnostics and ultimately up to cure. So this picture has been around. We are all familiar with a classification and additional classification, especially for perihilar, cholangio, also called Klaskin tumors, bismuth coleth. That guides us as surgeons depending on what you want to intervene in. So in terms of management, in Uganda, at least starting, the hospital where I am is 125 years old. It's a church hospital, but we've not been having routine hepatobiliary services up to around 2017. 2017, 2018, we went to India for some fellowship training in hepatobiliary. And when we came back, that's when we were able to start doing some hepatobiliary work. And based on these 3 classifications, intrahepatic cholangiocarcinoma, if we pick it early, if we are lucky to pick it early, at least we are able to do liver resections, similar to the way you do for HCC. Perihilars, personally, for the last 4 or 5 years, I've not seen an early perihilar carcinoma. And then distal cholangios are good because we're able to do Whipples similar to the pancreatic head tumors. And even with combined. So this is the data I have from Rubaga Hospital, the 125-year-old hospital with challenges from imaging and everything. And you can see, because of lack of advanced endoscopy, even the interventional radiology is limited. What I end up doing is I end up doing palliative resections just to palliate the jaundice and get the patients comfortable. And sometimes I'm lucky because the population is young. We don't have an elderly population, so I can get away by, especially if you have extrahepatic obstruction. I can go as high as lowering some hilar plate and you do a bypass. When you do a bilioenteric anastomosis, the bilirubin goes down, and then we send to the oncologist to give some further palliative chemo. We don't have the new drugs that you've been discussing. I've basically been learning with your immunotherapy and the rest. We don't have that. A few patients who have money, we send them out of the country. And this data, we published it in the World Journal of Surgery recently in Feb, and it's available there. So surgically, I'm happy because if I get a patient who needs a resection for a liver resection for intrahepatic cholangio, we can handle it in country now. We are able to do Whipples if you have a distal cholangio. But the challenges of if you have an elderly patient who can't stand disrupt these complex surgeries, and you need to give, who needs to benefit from maybe an intervention or advanced intervention endoscopy or radiology, that's where we have key challenges. So the challenges, we have, of course, late presentation. I've also had issues with preoperative resectability determination. Sometimes the radiologist gives you a beautiful report saying the tumor is resectable. Then when you're on table, you get a big surprise. The vessels are encased, and you go back after the surgery to complain, but I think over time we'll improve. We have few HPB surgeons. Fellowship-trained hepatobiliary surgeons in Uganda, we are 3. And we've been interacting through Africa Hepatobiliary and Pancreatic Cholangiocarcinoma Consortium. And we meet, and most of my colleagues across the continent, in fact, most of the countries have one or two, apart from South Africa and Egypt. but the continent has few surgeons. Out-of-pocket payment, which is a challenge. You have a poor population, and they have to pay out. We don't have national health insurance. Of course, multidisciplinary teams. You have 3 particular surgeons. We have 1 cancer institute. Here you have 1 hospital with everything. For me, the cancer institute is somewhere else, the hospital is somewhere else. So sometimes they discuss the patient, then they send to you just for resection. And then we have some, but with technology now we can communicate via Zoom and the rest. And then of course the usual things, no EUS, which could benefit those advanced cases that need just palliation instead of opening to do a palliative procedure. So we've been trying to advocate through our society to ask government to try to intervene, but there are too many priorities. Surprisingly, when we have politicians who are sick, they fly out of the country. So we're trying to negotiate and see if that money can be used to boost the local capacity, especially in diagnostic and the rest. And then when I was interacting with my friends from Mayo through Matt and Professor Robert's team, we want to see how we can get some of these specimens. We pause, I do about 7-8 hour procedure. And we resect, you get this specimen, you give the pathologist, and all it gives you the information about the histological classification. But we wanted to see how we can contribute to the beautiful research you people are doing by providing these specimens, instead of them getting wasted in the continent. Thank you.
Thank you to all of our speakers. If we could have everyone at the table or online, we're going to take 15 minutes for a panel discussion.
So 15 minutes are precious, so I would like to ask the audience first if there are any questions. And I hope there are, yeah, I see people with microphones. Are there any questions from the audience to the panel?
Mic 4.
Well, first off, I want to congratulate everyone for...
Yes, we can hear you.
Okay. Yeah, I want to congratulate all the speakers for highlighting the challenges in their own countries, institutes, and regions. Many of those seem to circle around drug approvals and coverage from governmental and other bodies. Do you see some common threads that could be an area of focus for the discussions that will follow tomorrow pertaining to regulators, or do you think these are more access issues that require a separate group that we need to bring to the table? And any of you feel free to jump in and answer that question.
Even though I'm just the moderator, I would like to answer that question. Because I think this is, even though I come from the Netherlands where we have lots of money, we actually have hardly any drugs available of all the FDA and EMA approved drugs. And I think it's a double sword, because on one hand, you don't have the drugs available, which are standard treatment in most of the countries. But on the other hand, the improvement with the new drugs are not that great, to be honest, in months or years or something to have benefit. So the improvement for us, or the gain for us in the Netherlands, is that we have a very high percentage of patients who are referred now to be part of new clinical trials. So I guess if we have lots of standard treatments, then there is a low incentive to have better drugs and in better studies. I guess that's the only answer I can give. But please, this is just from the Netherlands.
I want to add that, yes, in countries, for example, like us in Spain, in which it was so difficult to have access to the new drugs, I think the access to the clinical trials is the best way to help our patients. Also, for example, we don't have NGS reimbursed in our country, and sometimes it's only the clinical trials in which the patient can access to NGS. No? So I think it's the best way, and it's something that we try to push, but in our database, we have the data that less than 10% of the patients in our country are included in clinical trials. So something that I think we have to improve.
Another question. It's hard to see from here.
Mic 4.
Yes. Microphone 4.
Thank you very much. Great session. Really appreciate all the speakers and really appreciate the discussion in the spirit of global collaboration. My question does focus on clinical trials accessibility and collaboration, particularly for a rare disease. I will focus on gallbladder cancer just because of the conversations I've had in the past regarding how we can improve this. So Bruno and Vikas and I, and I've also talked to colleagues in Korea, you know, there's trials that run, and the focus will be more on NCI trials. I think industry-funded and industry-run trials have a little better opportunities to overcome some of the financial limitations and some of the government regulatory limitations. But how can we, particularly someone like you, Bruno, who's involved at the government level in Chile, how are we going to overcome the government regulations and hurdles and the financial limitations to do global collaborative trials? For example, the gallbladder trial, we tried to open in Chile, we couldn't. We tried to open in Tata, we couldn't. I'm struggling trying to open it in Korea. We're still going through all of these regulatory hurdles. So how can we overcome that? And will it take, does an organization like this, patient advocacy organizations working at the NIH level, NCI level, is it going to take that kind of impetus and push to try to get this to overcome these hurdles?
It's a great question, Mirin. As we could feel and know again today, we have different problems in different countries. It's as we live in different planets, but in the same planet, no? So we have to try to eradicate a parasite, or we have to try to get an ultrasound in some places, and in other countries we have to try to get the best treatment even before it's approved by the FDA. So we have different kind of problems, no? So I really believe that global collaboration is essential. So when we spent maybe 5 or 6 years ago with Juan and with you, and we designed a neoadjuvant treatment for gallbladder cancer, and we wanted just to give GEM-CIS before the wedge liver resection. In my country, it was, and it's not yet possible because the legal regulations obeys to have the complete payment from a company from somebody else for a treatment that is going to be administered in a clinical trial. So we're trying to change that because this is ridiculous, but we're trying to change that, and we're getting close, but we have been spending 4 or 5 years. So now we convince the Ministry of Health that they should pay for treatments, and we can randomize them in order to learn and to build our national regulations, our national guidelines with our research. So to answer your question, I believe global collaboration to implement a cancer registry in my country, that it could be very simple for many of you here. It has been very hard in my country, but it's very relevant if we want to learn about how to improve opportunities in gallbladder cancer that is going to disappear as a problem. So do global research. It's mandatory for a community like this. Mm-hmm.
I'll just add to that. I'll answer in 2 ways. One is early detection, and then the second part is treatment. Now, they are doing laparoscopy or cholecystectomies in patients with gallstones. In our country, that gallstone is not only the problem. And if we have early detection, do we have enough surgeons, enough pathologists to look at the gallbladder specimen? There are many studies who are looking at early detection might help in early diagnosis, early stage disease. But I think collaborative studies doing across the globe with the areas where, like Chile and India, then putting the data and then pushing the government for kind of implementing the health policy for early screening, that would be something useful. Second part is the treatment. Gallbladder cancer, the benefit of immune checkpoint inhibitor is very small. But if you look at the triplet chemotherapy, the benefit is pretty good, and we are looking at the trial. Now, there are two ways we are looking at it. One is to do a trial. We can expand it to multicentric collaborative trials, and low-dose immunotherapy is something which, and our government is supportive for low-dose immune checkpoint inhibitors so that the benefit can be given to the patient at the lesser cost. And these trials can become global so that the value of this, that multicentricity would add a great value to it.
Thank you.
Important remark, I would say. There are several questions from this side. Juan?
Thank you very much. A great session. Very often our focus is on advanced disease and the latest drugs for advanced disease. And I was struck by the experience in Taiwan, in Thailand, and in India, that actually you can reduce the problem with prevention and screening. I know you've just spoken about early detection. How can we expand the lessons and the benefits that we're already seeing in prevention of the disease in the first place beyond your countries? How do you see that we can do this in Southeast Asia, in Taiwan, India? Just your thoughts, including Thailand.
Who would like to start? Bruno, maybe?
Yeah, it's a very good question, Juan. I'm sure companies here from the States could be interested to give money to get NGS from people from my country. And with this money, maybe I could implement a registry or to do something else good. So maybe to face the problem as a global community and try to take advantage of things that you could use from your near necessities could help somebody else from abroad. So I guess to have samples from all around, NGS genetic information is going to be very helpful for everybody. And maybe with this money, we could help the development from the first steps that we need in I belong to a developed country with problems from developing countries. So maybe we could improve some steps with the help of the global community. Mm-hmm. But it must be useful for you, so not just charity, because with charity we're not going to change in reality the world. So we must go more ahead. So I would really love to bring to my country all the passion that you have here in the Cholangiocarcinoma Foundation. And we have made important changes in my country with the pressure from the civil society in the streets. And we duplicate the amount of money that we spent in cancer in 2 years, just because political people, they had the numbers in front of them. So just to generate this information, it makes it impossible not to go to the following step. Mm-hmm.
Maybe an addition from Thailand, Professor Loilome?
Thank you so much. I would say that I quite agree with the previous answer. I think in case of Thailand, I think we do have quite effective tool in hand. And then, as I mentioned, we adopt some of the program to be implemented in Laos. And then we, as mentioned previously, Professor Nalong really want to expand this program to the other, country in Great Mekong sub-region as well. So the challenge would be the budget, I said. So in this case, if we can raise up this thing to be regional or the global issue, and then draw attention of the global agency to pay attention, and then I think we can do these missions. Thank you.
Thank you. There are more questions. Angela? Oh, the microphone.
Is off. Hello? Okay.
Yes.
Thank you, everyone, for your beautiful lectures, because actually what we wanted is to see how much of a global problem this is and the disparities we have, and I think that was pretty clear. And I think to me something really striking is the fact that what is required in each country is totally different. I wonder whether for a change, for getting a change or for inducing a change, whether maybe having a list of what is absolutely the basic necessary, because in some countries that is an ultrasound, a CT scan, and then we go up is access to care, access to drug, access to novel drugs, access to NGS, and depending on where you live, the problem is different. Sometimes if you bring up a list of what is absolutely necessary across the globe, so all the patients, wherever they are born, they can have a good cancer care, sometimes you can involve, I'm thinking of, for example, WHO and have that type of support. Do you think that that could maybe bring up all the problems together and probably solutions?
So I only have to add that it's very difficult to plan solutions because the problems are so different. No? Something that I think we have all in common is the necessity of awareness. So I think that's in common. Even if you need an ultrasound or even if you need an NGS or whatever, I think what we can do is awareness in our countries about the different levels in the GP, in the patients, in the oncologists, in the surgeons. And that's something I think we have in common. The rest, it's very difficult because the etiology, the problem, the dimension of the problem, I think it's so different from the different countries. No?
But if I understand correctly, what Angela actually suggested is if each country has a top 3 easy reachable problems, is that then to get that an overview per country?
Yeah. So for example, I know there are some initiatives of a list of what is the absolutely minimum chemotherapy drugs that are required and they are a must. And for example, the ESMO has been working on that type of initiatives. So shall we come up with what is absolutely necessary for management of biliary tract cancer and move that forward?
That sounds like a great...
to put together.
Yes. I think there's time for a last question from Kathy, I think.
Thank you so much. I'll echo Angela's comment. This is a beautiful session, very, very interesting. My comment is for any of the panelists, but I guess spurred by one of Teresa's comments about lack of a control arm or the issue of single-arm studies, noting that we're a rare cancer overall and that many of the molecular markers are even more so rare and that we are going to continue to generate single-arm data. I was wondering for Teresa or others, does the existence of any control arm, such as a non-comparative concurrent control that may not even be molecularly matched but is potentially, say, in a platform trial running concurrently, would that help with some of the reimbursement issues which may be independent of the approval issues, having any control arm that's contemporary, or does it need to be really a truly randomized control arm?
Our experience in Spain, for example, with pemigatinib, that it takes more than 2 years to be approved. One of the main problems was we don't have a control arm. So I think to say, okay, we have to randomize the patients, I think that's crazy, no? And we know it and we are convinced of this. So for me, this real-world data of the patient with the same characteristics, so I think we have to generate this data, very well generated, and with this we will help to convince the authorities. It's not the same, of course, it's not a randomized trial, but it's something that can help us to convince the authorities with the control arm. For us, it will help a lot in order to have the reimbursement of this kind of trial design. Yeah.
Because this subject is so important, I allow final remarks from Juan.
So I'm here. Just a very quick question to Michael. How can we as a community help you in Africa? The lack of resources was very striking, particularly with surgery. How can we help?
Thank you. If you can, I don't know that it's polite to ask directly, but you can help us with the things we are looking for. But also, we know developed nations, you have influence on our governments. So through advocacy, I think if the directors of Cholangiocarcinoma Foundation reached out to our Ministry of Health, I can help connect you. Maybe the priorities might change. But it's very heartbreaking to practice in a situation where, if you had this, you'd have helped the patient. And even when we look at ways of collaborating, there are less risky ways of getting samples. If I wanted to collaborate with and support the beautiful work you're doing, there are less risky ways of getting samples as opposed to getting them when I don't have the things to use. Right now, we are trying to fundraise to upgrade our CT scan, which is a 6-slice CT scan, to at least a 64 slice. So you improve on, so that I don't have to operate on patients who may not have needed that operation. So having such problems, you can only improve by at least improving on the basics. Thank you.
I think this is the time to finalize this session. I would like to summarize, just to give the CCF a list of things to do. So what are the things we need is 3 things I take away from this session. Is 1, to know the top 3 problems to be solved per country. Second, to have a prospective registry, something for registry to do non-randomized trials with cohorts. And the third one was to learn from each other's experience. Thank you so much.